Welcome, everyone. Thank you for joining our webinar on unlocking the potential of health assessments. I would like to start our webinar with an acknowledgement to country. We acknowledge the traditional custodians across the lands in which we are meeting today. We acknowledge the waterways, the land, the sky. We acknowledge their ancestors and elders and recognize those who continue to protect and promote Aboriginal and Torres Strait Islander cultures. We acknowledge the past and stand together for our future. Before we start, we have some housekeeping. Everyone is going to be on mute and with the camera off on default. If during the session you have any questions, please use the Q&A chat box and we will do our best to go back to your questions. At the end of the webinar, there's in a new tab, there's going to be a survey. Please answer the survey as this will help us improve the quality of our webinars and to tailor the content to your needs. For those people who are looking to have a certificate of attendance, please fill the survey as in the survey, there's a specific question specifying that you need the certificate. You will be receiving the recording alongside with all the resources in the next couple of weeks. It could take up to 2 weeks for you to receive these resources. Now, without further ado, please, I would like to welcome your speaker for today, Jane Caligeras. Please take over, Jane.
Thanks, Julio. Welcome to our webinar on unlocking the potential of health assessments. For those that attended last week, this is the second in the series. That recording is available as well through the PHN and the resources from there. So what we're going to go through today, we're going to touch on a little bit of the Medicare item numbers for health assessments and then what's involved in those different health checks. And hopefully to apply that learning after you've done this session to perform those health assessments in your clinic. So we're going to have a look at the overview of the 3 types of health assessments. Within those 3 types of health assessments, there's a total of 11 health assessments. So that's why we're doing a couple of sessions on these to just break it down. We're going to have some time. I'm going to have a look at the screening tools that we may use as part of a health assessment or as a follow-up activity as well. And then I'm actually going to do a demonstration of a health check as well. We're going to have some case studies at the end. As Julio said, if there's any questions, just pop them in the Q&A and we should be able to get to those at the end of this session or if we don't have time afterwards as well. So let's have a look at the overview of the health checks. I've got one of our flow charts up for those that are aware there has been some changes with the Aboriginal and Torres Strait Islander health check, so that's 715 health check. And our flow chart kind of works through what is of most benefit to the practice as well as to the patient. So financially, these health assessments are worth different amounts of money as well. So our flow chart will start with, does the patient identify as a First Nations Australian? If that answers yes, it's always going to be the 715 health check. And that's because it does trigger a couple of things from a practice point of view. So it does trigger the payments that we look at for the PIP registration for this year, but it also triggers for the reporting and the outcome payments for those as well. So it's important that we do that as an item number. The changes are that it does access up to 10 allied health visits now from just the 715 if that's the actual 10 allied health. So instead of having 5 under the 715 and then 5 under a chronic condition, the 715 on its own can actually trigger those 10 allied health services. So I've got that on another slide with a flow chart to just hopefully make a little bit more sense of that. And then it also does, once this 715 has been triggered and billed, it does also allow for the 10 follow-up numbers, so the 10987. So if the patient doesn't qualify for a First Nations health check, then we look at, are they eligible for a time-based? So financially, the time-based is worth more than a heart health check. So that's why it goes down in that particular order. Now, the other change with the 715 health checks came this this year was that they can also now have a heart health check as well. So before it was in the explanatory notes that you couldn't actually have the 699, but the First Nation, so if the patient has had a 715 health check, they can also have a 699, which is good. So it allows us to do like health promotion days and things like that as well. So the time base is that second set. We're going to have a look at these different types of health checks in here separately. But if the patient isn't eligible for a First Nations health check, if they're not eligible for a time base, and you can see there's a lot of restrictions there. So it's the different age groups. It's broken down into they can only have a once only for some of those health checks, and some are once every 3 years. So it does make it really, I guess, difficult to align a health check with a patient sometimes. So the other one underneath there, and I know there's already been some training on this, would be the heart health check. So if they're not eligible for any of the other two health assessments, we can actually look at the heart health check. Now, this is a really, I guess, underutilised health assessment sometimes. But for me, it's a way to get a younger generation or cohort of patients into your clinics for preventative healthcare. So this is also the most difficult age group to get in. So that 30, 40 to 49, 45 to 49. So this is a really great time to maybe go back, have a look at that first session that we did and talk about ways that we can actually, promote and get those patients into the clinic. So I've got the 3 types of health assessments there with the Medicare numbers and the links to those descriptions. But I think it's really important to just make sure everyone's aware, like even the time-based health assessment changes. The reason they're time-based is because it actually does count the nurse or Aboriginal health worker time and the GP time in that, but they've also added additional information into those descriptions now. So it all comes down to the complexity of that assessment. So I think it's a really great time to just have a review of those MBS numbers to make sure that everyone's on the same page with what needs to, I guess, be completed. And that's where that last webinar with your tech shortcuts and things set up in the background can actually help to make sure you're completing everything that Medicare needs us to as part of that. We did provide just some extra information because it is a little bit confusing. There's still a couple of remaining numbers that can be completed with the different pathways. So face-to-face, telehealth and phone for the First Nations is still available. So it is just worth mentioning and having a look at those other items. The annual Veterans Health Check is different to the one-off Veterans Health Check. So the other ones are done through DVA. So it is just worth doing a bit of a refresher on the billing with your practice team just to make sure that everyone's across those new changes. Now, in that last session, we did kind of talk about one of the really big steps is how are we going to, where do we start? There's 11 health assessments, there's different age groups, how are we actually going to put a plan in place? And for me, it all becomes a process. We want to make sure that we're doing health assessments all the time, and the process of identifying those patients is actually quite easy. So I think the best place to start is by looking at your practice data. So what is your patient demographics? What does that look like? How many patients do you have? How many of those patients are aged between a certain age group that can allow you to recall them in for certain preventative activities. So I just wanted to mention quickly about Primary Sense. So it's a PHN owned and operated clinical decision support tool for general practice. It allows you to help with the population management, and it's a data extraction tool to provide the staff with real-time medication alerts, reports, and patient care prompts. So there is a specific report there that you can access for health assessments as well. So I've just got a couple of quick steps there. So if you missed the last session, you've got those slides here. And at the end of the session today, I've actually got a couple of extra slides on Primary Sense as well. And then if anyone still needs an additional support, just reach out to the PHN for that. So there are lots of different ways to kind of identify your patient. This is one of them. Other clinics are using, you know, other extraction tools. Some clinics are just using their clinical software. But basically, we want to look at our patient demographics and figure out where's our priorities. Like, how many patients do we have in that 40 to 49 age group? How many patients identify as First Nations? How many patients are, you know, over 75? So we really want to make and put a plan in place. So, you know, we've got our whole practice team, you know, working towards that shared goal of, you know, doing more preventative healthcare. So I've got our next little section. We're going to actually go through some extra little tips for First Nations and the time-based health assessments. We'll start with the First Nations health assessment. The Aboriginal and Torres Strait Islander peoples, there's actually 3 separate age groups. So the item number's the same, which is confusing sometimes when we're talking about, you know, the item numbers and the different types of health checks. But for me, I'm going to break down and give you the top tips for each of these health assessments. So the child health assessment is 0 to 14. In a lot of the clinics and the Aboriginal health services that I've worked in, we would actually do these a couple of different ways. Because we can do them from birth, we would actually try and align the 6-week immunisations with that first health check, which seemed to go really well. And then because we can do these 715 health checks every 9 months, we would line up the 12-month immunisations with that second 715. You know, the main focus on this health check is looking at, you know, early development, mum's pregnancy. So I think it just ties in quite nicely with, you know, the development checks and things that we're doing. So that is an option. It's something to think about. The adult health check, the 15 to 54, and I might actually just show you these in a little bit more detail on the next screen when I go out. So I might just switch that over now. So that's our 0 to 14. So you can see a lot of what Medicare, and this is straight from the Medicare descriptors. This is our training manual. So a lot of the things that they're kind of asking about is, you know, the things like family history, you know, immunisation status, you know, a lot to do with like mum's pregnancy, and then our basic checks. So the GP will kind of decide what needs to happen out of these, where it says like if indicated. So, but you can see there's a lot, and when I kind of go into the next health check, it's quite different when we kind of go into the different age groups. So the 15 to 54 will be our adult health assessment, and you can see that these adult health checks, so I kind of group them all together, even though they're this one's the Aboriginal and Torres Strait Islander health check in that 15 to 54. We've also got our time-based health checks that we'll have a look at in a minute, where we've got our at risk of diabetes, we've got our 45 to 49, and then we've also got our heart health check. So to try to not overthink it too much, like these are our adult health checks where people are actually, you know, they actually have a lot of risk factors in these age groups. And unfortunately, as we get older, we're kind of ticking a lot of boxes for some of those really big conditions. So, you know, this is where a lot of those, some of the CBM activities that we do in the clinics, and it might be screening for COPD or some of the other like big conditions that we do see, this is when we're going to flag it. So we're looking at risk factors, current health problems, and family history. For me, that's whether we're doing care plan review or health check. But you'll see there's really big mention of the different screening recordings that we need to do. So in our tech shortcut, I have those little prompts there, so don't forget to do a certain screening. This one mentions urinalysis specifically. My preference is to do a urinalysis on any health assessment, and that will be something that you might discuss with your practice as well. And then you can see there's additional examinations that the GP might organise as well for the patient. So you can see that's actually quite different to what we're looking at with that child health assessment as well. So any health assessment, we're usually going to end up with a list of things that we might need to do with some follow-up activities, and that might be back in for some blood results. it might be back in to do some other screenings or tests, or in these cases with the over 55 and the over 75, both of those health assessments, we're usually getting the patients back in to do some additional paperwork or referrals. It might be like the continence, paperwork or other aid, paperwork and referrals that need to be completed that you can't actually do in that health assessment appointment. So the over 55, you'll notice, even if you haven't done one of these before, but you might have done the over 75 health assessment, the description for these are exactly the same. And a lot of people say to me, Jane, why are we doing this health assessment and they're only 55? A lot of the patients in this age group, because they're at risk of other conditions, First Nations are higher risk for things like cardiovascular disease, chronic kidney, etc. So they'll usually have a couple of existing conditions and complications in this age group. So a lot of the things that we might be sorting out for non-Indigenous patients that are over 75, we're usually doing these in this particular health assessment. So it might be, ACAT referrals and support services that we might be setting up in the background. So you can see, same thing, we're looking at things like continence, medications. So a lot of patients in this age group will actually have a home medicine review completed if that's required. We're looking at things like activities of daily living and whether they need, additional supports in place. And then there's also the cognition and mood screenings as well. So depending on the software you're using, a lot of these screening tools are actually available in your software. So I'm going to show you in best practice today some of these screening tools, and then I've got the other ones just up ready that we can have a look at as well afterwards. So I think it's really good to, have a process in place. You can see even just from these 3 health checks, even though they're all under the same item number, we actually have to look at 3, different things based on their age related risks and, family history and condition. So there's a lot that is easy for us if we have this set up as a shortcut. So that way everyone in your practice will be recording the same information. Okay. So let's actually go back to the slide deck. We're going to have a look at the allied health pathways and the changes that have come about now with that. So you can see if the patient identifies as First Nations, they can access allied health services a couple of different ways. So as I said, now with those changes, we can actually do 10 individual allied health services, and that will go on that one form. Obviously different forms for different providers, but they've updated the form for that. Or we can use 5 individual allied health services and 5 under the care plan, the GP management plan and team care arrangement. So it just comes down to what the patient requires, but it's still a total of 10. And then the third pathway under here that I think a lot of people don't recognise or use sometimes would be if the patient has type 2 diabetes. So you might be doing a health assessment for someone that actually has type 2 diabetes, so they can access, those 5 visits under a care plan, or if it was a First Nations like health check, we could actually they could access whatever they're eligible for. So they could access visits under a health check, a care plan, and then the group services for type 2 diabetes as well. So any of those are possible. So patients can actually be eligible for both. So if it's just that they've got a chronic condition and type 2 diabetes, they can actually access like the 5 and the 8 if they didn't identify as First Nations. So this is why we need flowcharts, because there's lots of different, pathways and different ways that we'd actually do those referrals after a health assessment or care plan. So we're going to have a look at the time-based assessments next. I've actually got the links to each of those specific ones that will take you through to MBS. So you can have a closer look at the descriptions. But because we're actually going to have a look at this today together, I'm just going to bring up the chapter on the time-based assessment so we can have a closer look together. So as I said, for me, the adult ones that we're going to look at, the 40 to 49 and 45 to 49, from a health assessment point of view, we're doing very similar activities, even though the Medicare requirements are just slightly different. A lot of clinics will go to me, oh God, there's 7 of these health assessments. I've only ever done the over 75, or I've only ever done a 45 to 49. So just keep in mind that even though there are 7 health checks in this particular category, the most popular are these first 3. So the 40 to 49, which is those patients that are high risk of developing type 2 diabetes, and we have to use the OSRIS tool to determine that. So we're going to have a look at that together. The 45 to 49 health check, and over time, I guess this is the one that for me, a lot of clinics say, Jane, we are doing these particular health assessments, but people seem to start at 45. So I'm a big fan of trying to get these health checks done a little bit earlier. So I'm a fan of the 40 to 49 and the heart health assessment, because it does allow us, I guess, to get in those younger groups of people and hopefully modify their lifestyles and behaviours, so we can actually reduce their risk for things like cardiovascular disease and diabetes. So the 45 to 49 is at risk of a chronic disease, and this is pretty much every patient in that age group, isn't it? Because you'll notice when we do some of the screening tools, age is one of those biggest risk factors for a lot of conditions. And the other most popular health assessment is the over 75. Now, this is something that probably most clinics identify as doing on a regular basis. This is a great health assessment to get patients to book in for their next appointment. So, you know, when we're talking about improving the processes for identifying and getting patients back in for the health check, because we can do this one every 12 months, this is a great health assessment to get them to book at the counter on the way out. They're usually requesting it, that, you know, they're so used to having that done with other visits that they're doing to maybe like a specialist, where they're booking 6 or 12 months in advance. So the over 75, definitely, if you can, work that in as a process that you're automatically getting them to book out the front. You'll notice with the frequency of these other time-based health checks, the type 2 diabetes high risk, that's only once every 3 years. And the 45 to 49 is a once only. And I think this is where people start to get confused, because they're like, oh, well, they don't fit into that group, they don't fit into the other group. You know, how are we actually going to provide this as a regular activity? So this is where I think it's a really good idea to think about it from a big picture. So I'm just going to bring over one of my other screens so we can have a look together. Now, for me, the way that we can do this is pretty much, I think every person over the age of 30 can actually have a health assessment every 12 months. So the First Nations, it's every 9 months for the 715 health check, which is fine. But if they don't identify, we can go between these 2 other pathways. So if they're eligible for a time-based, great. So say today we did a 40 to 49 health check. I'm still going to get the patient to book in out the front. So say that patient is aged 40. We've done the 40 to 49 health check today. I'm actually going to get them to book back in 12 months' time, but that's going to be under a heart health assessment. And then I'm going to keep going for the heart health check every 12 months until they might meet that criteria for the 45 to 49. And then I'm just going to go back and forth. So for me, that's a really good way for us to be able to get patients to come in for a regular annual health check. And I think that's a really important part. So obviously, if we can start younger and get these patients in from age 30, so start recalling those patients now. So a lot of clinics are starting to do the 30 from 30 up. So they'll recall patients from 30 to 39, and then they'll recall patients from 50 up until 74. So they'll kind of do those in between groups. But I think just take it that next step further if you can, and think about it from a big picture. If patients are eligible to have a health assessment every 12 months, the name of the health assessment, I try not to get too caught up with. I just call them all health checks when we're discussing these with patients. But from a Medicare point of view, it'll come under a different category. So it'll be the type of health assessment that you'll be looking at. So I hope that's not too confusing, that I've made it more confusing. So those first two, I'm going to actually do a demo with a time-based health check today. So we're going to have a look at that together. The 45 to 49, they're looking at exactly the same risk factors. So we'll have a look at that together. So those non-modifiable risk factors and then the modifiable ones. So we're, I guess, asking those things all the time. Are they smoking? Alcohol intake. So I'll fill in those when I do my little care plan demo, health assessment demo, and you can see that as we go through. The over 75 health check can be quite detailed, as well as the patients that have an intellectual disability and the aged care home. So if your clinic are doing a few of those health checks, this is where, I guess, when we spoke about in the setup, I prefer the same amount of time for a health assessment, regardless of the health check. So even if it was a heart health check, because I'm looking at the big picture, not just specifically the cardiovascular risk like alone, I still prefer anywhere between that 45 minutes to 60 minutes for the nurse. Clinics might do that a little bit differently. So it might just be with the GP that they have it set up for the heart health check as an example. The time base might be 30 minutes with the nurse or Aboriginal health worker, and 30 minutes with the GP, or 15 minutes with the GP, 20 minutes, etc. So I try to keep it simple as a process, and we decide on a time. And because a lot of the time we're, I guess, identifying other things that the patient is due or eligible for, and it might be that they need to come back for, one of the cancer screenings that we do in clinic, like a skin check, or it might be, cervical screening, or they need to come back for the COPD screening. So I think it's the time of that actual health assessment for me stays constant, but it's something to discuss. But just recognise that the over 75, the aged care home health assessments, and the intellectual disability might take a little bit longer to actually complete. The humanitarian entrance, for those that might not have done one of these before, a lot of the training that we do, I think it's this one and the former members of the ADF that a lot of nurses and GPs might not have done before ever. So I'm going to show you in best practice the ADF. It's actually got a template already set up for that. But for those that might not have done the refugee or humanitarian entrance, I've done a couple of those. I guess for me, it's something to just consider. You might need to allow extra time, especially if you need translators and things involved as well, which we have had before. So it's just something to think about, I guess, from a time base. What we're actually going to cover in the health assessments, as I said, is pretty much identical with the little tweaks with what Medicare needs us to record. But for myself, I think the actual process of gathering that information will remain the same. So they're our time base. And I think if you're not sure of where to start and you're not doing any health assessments right now, I think once you break down your data, you'll be able to kind of put like a priority list together and put your process into place. So we'll have a look at the time-based health assessment in a second together. And I'm just going to quickly mention the heart health checks as well. So I know there's already been some training delivered on this. I guess the big things around the heart health check was that they did decrease the age. And I think it's a really good thing that it kind of came down offering as an age group, because for me, as I said, this is a really, I guess, key time for us to recognise risk factors and reduce those risk factors if we can. And I think getting that that younger generation into the clinic before something happens, like before an event, etc., like whether it's a heart attack or something that happens in that 40s and 50s, if we can actually reduce that risk in their 30s, I think that's a really good time to do it. The thing to consider with the heart health checks will be the workflow. So if we're recalling patients in a younger age group, they might not have had a cholesterol reading done before. So it might be just discuss this as a process with your practice team. and then decide the best way to, I guess, do that workflow. As in the GP might recognise that they're eligible for a heart health check, do the pathology request when they see them, and then get them to book back in as a health assessment with the nurse and GP. And we do that as well with the 40 to 49 and 45 to 49. So some clinics will send out, pathology forms ahead of time and then get the patient to book in. So it all comes down to the process that you want to complete in your practice. I've seen lots of different variations. So there's no right or wrong. It's just you want to make sure that it's very clear so then everyone's on the same page. One of the other big questions that I get around health checks and care plans, it's what do we need to record for a health assessment? Myself, it's going to depend on what the patient actually has as existing conditions as well. But most adults, we're going to be doing like a height, weight, BMI, waist. Waist measurement is really important because it will actually help us do some additional screening tools like the OSRISC. As I said, I usually do a urinalysis as the minimum for any of the health checks that I've done. Some clinics will do an ECG as an annual, as part of that health check. So we do that usually, especially for the Aboriginal and Torres Strait Islander patients, we'll do from age 30 as part of that health check or as part of the follow-up. And so a lot of clinics will do the same for a 45 to 49. They'll include an ECG as part of that follow-up as well. So this is something to discuss as well. If to help on board your, I guess, new team members, it might be good and helpful to actually have in brackets, respiratory rate. You'll see my little example of the tech shortcuts that I've got as well. I actually prefer to have that written as it helps a lot of the junior staff coming on board to know what to record for the particular health check that we might be doing. So as I said, the main part of the health assessment is to actually identify and hopefully modify some of their risk factors. So we've broken it down into a couple of sections. So we've got our non-modifiable risk factors. So as I said, as we get older, depending on gender at birth, so males are more at risk of things like heart disease, etc. So recognising patients at risk. For me, the family history is really, really important to record. So I'm going to show you that as well. And then we've got ethnicity. So depending on country of birth and ethnicity, it will also put you at risk for a number of conditions as well. Our non-modifiable, our modifiable risk factors, so things like smoking, alcohol, nutrition, physical activity, physical inactivity, and weight, can be modified. So if we recognise that, these are higher than what they meant to be, or that a patient identifies as smoking, etc., then we can actually address those as part of that health assessment and follow-up. So for me, this is a really good time to get your resources and have them ready, because this, especially around the modifiable risk factors and encouraging patients and maybe even setting up the referrals and things for the lifestyle modification programs, you're going to need some resources that you can actually hand out to the patients. So if you're not sure what the next steps are, so if a patient comes in and you're doing the health check and they go, yes, I'm a smoker, I'd like to quit smoking. If you're not sure what those next steps are, I'd refer back to health pathways and have that conversation with your clinics, and especially things around, I guess the most common things are like losing weight. Someone might want to, reduce their, alcohol intake or increase physical activity. What do we do next? So if you're unsure of this is a really good time to sit down with the practice team and, come up with those resources that you're going to be using, because this is every single patient that we're having these discussions with. And I think for me, from a nurse background and point of view, this is something that we're really good at assessing. But sometimes it's those next steps or maybe some information that we might need to provide to the patient that we might not have on hand. So like I said, it's a really I guess, great part of the setup to make sure that we've got resources that we can pass on to the patient. And then our lifestyle modifications, it's really hard, I guess, to be generic enough to say this is the program that's available. There's some clinics that are running their own weight loss clinics. Some clinics have their own, walking groups. It's really important to know what those options are. And I think for me, if you have those options available when you're having these discussions, makes it easier for the patients to commit to doing that next step. But if we're saying, oh, I'm not sure, let me just find out and then I'll give you a ring later, sometimes they lose that momentum of actually going to that next step. So I think find out what's available, find out and have a couple of options. So it might be that there's a free program, like a walking group as an example, and then you might have a low cost option that might be, a class, a dance class, or some other activity that isn't a high cost, and then the patient has some options and they can choose. And especially when it comes to referrals to external providers, we want to make sure that we're actually giving them those choices. Because I had it happen, quite a few times. They'll be like, oh, well, they wanted to charge me $30 to see the dietitian, and I couldn't afford that. But if you know that up front, then we're going to make those decisions earlier, and then we're actually referring them to the correct provider, etc., that they are, happy to see. The next little part I've got is just on a care plan versus a health check. And I guess this is the main question, what's the difference between a care plan and a health assessment? And from an information gathering point of view, for me, I usually say not much, because we're asking the same questions, we're updating the details, we're recording observations, we're still looking at all of these things. But I guess the health checks that whole patient and I guess holistic approach to their health and well-being. So patients will want to know the difference as well, because they say, didn't I just have that done, when we're doing the health assessments and care plans sometimes. So I think you're going to have your own description of what that is. But for me, it's to, improve and identify those risk factors. So the actual process is very similar, but it's going to come down to how you want to explain that. But for me, especially when we get to the patients that are over 75 or over 55, the Aboriginal and Torres Strait Islanders, we're actually doing a lot of paperwork after those health checks. So it's just, I guess, how you can explain it. And, some clinics will, sometimes bill these two item numbers for a care plan and a health check on the same day. So if that's the case, then, you'll be explaining it a little bit differently as well. But for me, I prefer to keep them as separate activities, and it's mainly because of the paperwork and the time that it takes to, I guess, generate some of that. Okay, so I'm going to just show you the screening tools next. So you can see I've got the links there to where you can get some more information or the screening tool directly. But even observations, don't forget that they're actually a prevention and early detection tool as well. Our immunisations, the health assessment itself as well. And then obviously we're doing things like cancer screening things within the clinic and part of those activities. So when I'm doing a health assessment or a care plan, I'm actually looking to see what else is the patient due for. Are they at risk of any of those major conditions? Do they need to come back for any other screening activities? So what I'm going to just show you quickly is the screening tools that are available, I guess, outside your clinical software. And then I'm going to jump into best practice and we're going to have a look at one of these health checks together. So this is a really good time to, I guess, set up those screening tools that are available outside your clinical software. You might prefer to order in some resources. So for the diabetes risk, a lot of people are going to go, no, it's in best practice. I don't need to order any of those. I prefer the PDF version, and that's just my preference. You can order these in for free, so you don't actually have to kind of pay for them. But what I like about it, I'm just going to download the PDF so you can see what I like about it. It's all on one page, but it folds up to be in that little DL format. So some clinics, when they're trying to get patients in to the clinic for one of these health checks, will send this out within a letter, an invitation to kind of come back into the clinic and have a health check. So they'll kind of recall that list of patients, 40 to 49, send out this with a letter saying, complete this and bring it back in. You might be, eligible for a free health check. I know a clinic that did it as a birthday card with this kind of printed on the inside and sent that out to their 40-year-old. So I think the engagement part of it that I've had with this particular form as a hard copy is a lot better than me just doing it on the screen in the software. And that's just down to my personal preference. But what I like about it is the patient can actually see their risk there in front of them when we're filling it out together, or if they're doing it on their own. So I usually start with the score and what it means. So for that 40 to 49, for that time-based health assessment that we're going to be looking at, everyone thinks that 12 is really hard to get to. So if you've never done your own AusRisk, I don't want to be a bearer of bad news, but it's very easy to get to sit in that high score. But I like to start with the score range when I'm talking with the patient, because I really want them to understand that 12 is the high risk. So anything above 12 is a higher risk. And then once we start going through, you can see that it doesn't take long. So as soon as you hit 35, and this is where the age part of chronic diseases and risk factors becomes very real, as soon as you hit 35, you start getting points, and that point, keeps going up until we hit the maximum of 8. But if we're looking at these age groups, where we've got our 40 to 49s, our heart health checks, and the Aboriginal and Torres Strait Islanders, all in those and the adult age groups, and for our heart health check, as soon as you hit 35, they're going to be getting points. So if you're seeing a lot of patients in these age groups, then you're going to start recognising the point system and recognising people are at a high score before you even take a blood pressure. So you can see if you're a male in your 40s, you're either 2 and 3, which is 5, or 4 and 3, which is 7. So 2 questions in, and we're already sitting at 7 points if that was over 45. So you can see ethnicity and where you were born will kind of allocate points. Things like gestational diabetes, 6 points. So it doesn't take long to add up. And most people are in the fetal position by the time we get to the waist measurement. So, I think for me, I've seen some really engaging behaviours from patients when I'm using that as a hard copy form. But I'll show you when we're going to best practice that, you don't actually have to use the hard copy, but I still put it on the clinical software, but I usually give this one for the patient to take home. So even if they don't look at it today or rip it up into tiny little pieces as they leave in the clinic, they've got something to refer back to, and they can see where they can get points back. So once we've got that final score, we can always go, look, if we can get you to do some more exercise, here's 2 points that we can take off. If I can get you to quit smoking, if I can get you to, increase your, fruit and veggie intake. So it doesn't take much to make some changes, which is those lifestyle modifications that we're actually talking about. And that's where they overlap across multiple conditions. For those that haven't seen the updated cardiovascular risk calculator, I recommend jumping in to having a look. I'm not going to go through that in detail today, as I think it's probably been covered with the heart health check as well. One of the screening tools that I do prefer to do as part of a health assessment, a lot of these other ones we might do as follow-up after a health assessment. But for me, the one that I prefer to do on the day, because I've usually done a urinalysis, would be for the kidney risk test. So it only takes a couple of minutes. You can literally just click through and go through the questions, and then I would just copy and paste that into the notes, or I'll show you an example of a text shortcut that you can turn that into as well. So this is one that I would usually do on the day of a health assessment. That's my preference as well, but you might decide to do some of these other screening activities after as one of those follow-up activities. Okay, we've got the COPD screening, same thing. You might do that as a follow-up activity. We've got the osteoporosis risk assessment as well. So this one's also been updated if you haven't had a chance to have a look at that. And then we've also got some of the cognitive screening tools. So this one's the KICA resource for the cognitive screening for the Aboriginal and Torres Strait Islanders. So I think it's definitely worth having a look at these different screening activities and deciding what it is that your clinic will be focusing on or using. So some GPs will have a preference, as an example, of the cognitive screening tools that they want to use. Okay, so I just want to show you a quick health check. I've done a couple of cheat steps already, just so you can see them. But in that first webinar, we did look at the autofills. So what does that actually look like to do a health check? So I prefer to have the different text shortcuts set up. You will have access to those that did the first webinar to our text shortcuts, and I'll put it in for this one as well. So for me, it saves me typing. I don't have to overthink it. I've got it all there. So depending on the health check I'm doing, I'll just select that and add it into my notes. And I do take a couple of minutes before I call the patient in from the waiting room to fill out as much as I can from here. And that's because it's going to give me an opportunity to have a better discussion with the patient. So I've actually got an opportunity to engage them more in that particular appointment. And it also allows me to see, oh, okay, I can see you haven't had any bloods done, or, I can see that you've, been to the cardiologist recently, etc. So it does help to have this filled out as much as you can, just from an engagement point of view. Now, I just want to show you the Ausrisk tool and where all the other screening tools live in best practice. So up in clinical, you can see we've got diabetes risk, we've got the previous cardiovascular risk calculator there, not the updated one, but you can see there's K10, we've got the mini mental, we've got the geriatric depression screening as well. So you can go in and use these separately, depending on the health assessment that you're doing. So for this one, obviously, before we start this health assessment, we're actually meant to have done the Ausrisk tool. So in a lot of the clinics I've worked with, we'd actually flag it earlier and then get the patient to book back in. And usually when we flag it, the GP will order bloods and then we have all the results when they come in. It just depends on your practice process. So you can see from an engagement point of view, if I just did this one with the patient, it's not as engaging. And they can't see where they can get those points back. So for me, I would still enter it on here, or you might want to print it off and then highlight the sections where they can get it back. But I like it on the tool because it actually says how many points they get back, etc. So you can actually have it as a quick reference. And you can see it records when we've done it in there. So, I'm gonna, what was my little score? 28. So very, very high. The family history, etc., is really, really important. So I'm going to just jump in to show you mine that I've got set up. So BP makes it really easy. Medical directors got some easy ways to kind of record as well. But my preference is to make sure that we've got it all recorded. I also like to put, the siblings, and it's mainly just the way it lists this. 2 brothers and 1 sister as an example, and I might put, one, brother died, age 34, MBA. So it's just when this prints out or pulls across into whatever documentation we're putting together, that will actually sit nicely in a summary, where I do add things in here, but it's more that it ends up in a bit of a blob. So it is important to kind of record that as well. The social history, I make sure that this section I'm very particular on all kind of completed, because we do identify risks from here, but if we do need to refer or do any other referrals out, like the patient might be a carer, so we might do a carer, strain risk tool as well, as an example. So it's just really good to have that information. For those that are interested in the COPD screening, obviously occupation, I never did this really well back when I first started doing a lot of the CDM activities as the nurse, but For me, I'm very particular about this section now. So there's certain occupations that will put, patients at risk for other conditions like COPD as an example. And then smoking and alcohol are going to be important because they're our modifiable risk factors as well. So this section is really, really important. And I know it does take a little bit of time when you're doing that for the first time as well. You can see I've got the little prompt there for the observations. So I will just record those all in one. It's actually really easy. It's under general. If you're doing a urinalysis, you can add that in as well. And your visual acuity, we can add in. So it's really easy to just kind of record what we need to in the right spot. And then I've got my prompts to record anything else that I might need. As I said, when we're identifying all these risk factors, a lot of this will be able to be completed as additional activities. So those prevention and early detection activities. So are they due for any immunisations? I would just write down anything that's due in the next 12 months if it was. So it doesn't have to be a very big essay or anything, but it might be, due for pneumavax as an example, and I might just put them on. Just so I know when we need to kind of record them back. If, you can see why I don't like typing. So skin check overdue. That just allows me, and some people will go, why are you doing this here and not in the actual health assessment document? What I like about doing, I guess, a little progress note shortcut and filling in the blanks is because this information will always be in those previous notes. So a lot of people won't go back and open up the last health assessment and review everything that was written there, but they will kind of scroll back through and have a look at previous notes. So for myself, I still prefer to use that format. Once we've filled out everything, we've recorded the observations, I can then go in and pull this across into a Word document or the letter document if that's what you're using. So some clinics will just use the letter document. I can actually pull those across. We've set up our templates so everything just pulls straight in. And then we've done a custom field, so I can just use this one template and then just pick which health assessment I'm doing. And you can see it pulls across those notes straight away. So I've worked in clinics where we only used a letter template for our health assessments. And then I've worked in other clinics where we only use this section. And this section, depending on the health checks you're doing, you can only use it for the 45 to 49, the Aboriginal and Torres Strait Islander health checks, and the over 75. It's just formatted around that age groups in particular. So it's going to come down to personal preference. It's worth having the discussion so you know where everyone's doing it consistently, I guess. So there's no right or wrong. It's going to be whatever's right for your clinic as well. So I hope that clears up, I guess, the actual information gathering of the health check. The lifestyle modifications, this is where I might put something like, smoking cessation, and it might not necessarily be that the patient is ready to quit smoking, but we've put it there as one of the things that they can modify to reduce their risk as an example. Some of the other activities that might be due might be that we need to get them back for some of these activities. And these don't have to be today. And it might be that, like we do a care plan, it's a 12-month plan. This is our 12-month plan for what we've discovered in the health check. So I think don't get caught up and go, oh my God, I've got to do all of these things today. It's more about gathering all the information so the GP has that full picture to review, and then everything is going to become a next appointment. So it might be that I'll get them to book back in for their skin check, and I'll just get reception to book those, and I'll get them to book, a health assessment in 12 months. Like I'll adjust whatever recalls and things that I need to in the background, but it just means that there's actually that opportunity for them to book that out the front. So I hope that makes a little bit more sense, but for me, the tech shortcut, having that template set up and ready to go, makes my documentation actually a lot easier to complete, and it makes it streamlined. So the GP knows exactly, where to go to from there. They can take that over, finalise and organise any further investigations and next steps for the patient as well. I just want to finish with one of the case studies, and I'll leave the other two to go through as well. But it's just I guess, a way that we can start recognising that patients are actually eligible for a health check. Because a lot of the health assessments that are going to be due, some of these patients might not be coming in for regular things like a care plan review or even a checkup. So I find a lot of the patients that I identify for a health check are usually coming in acutely through the treatment room. And it might be that they've come in for, a wound like this gentleman. So you can see, Stuart, 42-year-old man, that's presented for wound care, smoker, overweight, already on antihypertensives, no previous health check or care plan. So I guess for me, every single time I'm seeing a patient, I'm asking that question, what are they due for? And the reason I want to try and, I guess, get it into a bigger activity is because we've got the time to look at the whole picture. So what things are, what are the current risk factors, what are the current health problems, and then what else needs to be done over that next 12 months. So I guess my first example is that I've got, obviously today they're booked in for a wound appointment, so I might not have long, but I could do the wound. I might have time for the Oz risk, but I could actually get them booked in for, as the next appointment, I'm going to get them to come back for the wound care, and I'm going to get them to come back for a health assessment. Look at all the things that need to happen over the next 12 months, though, even from not even looking at the patient but without even recording anything else, just based on the age, you can see other things that might be due. So even if we got them back for a 40 to 49, we could get them back for a heart health check within that next 12 months. They need blood stuns, hin check, spiro for screening for COPD, some of the other screening activities as well. So this is a really good time to, I guess, as a practice, decide on those follow-up activities. If you are going to do things like COPD screening, what does that involve? Do you need other tech shortcuts and appointment types set up as well? Next one, I was a big fan of recalling the list of over 74-year-olds. So if you've got nothing to do and you're a bit bored, you can recall the list of over 74s and get them booked in ready for as soon as they turn 75. But same thing, this patient's coming for just some scripts, but I would actually book in for the over 75 health check, even though they're not 75 yet, but I would book it in for when they're turning 75. And obviously back in for care plan or other activities as well. But the list of activities and I guess things that are due from a chronic disease or risk prevention point of view, it takes time. So you won't be able to do any of these all in one day. But I think that's what the beauty of that next appointment is, that we're just going to keep working our way through this big tick list. And then I've got Stacey, 45, in for a flu shot. Same thing, Indigenous, ex-smoker. Last 715 was, 12 months ago. So in for a flu shot, I don't have time for a health check today, unless, you've got that, opportunistic way of the bookings and appointments. Obviously, if I have time, I can offer it, but if I don't, then I'm going to get them to, book back in for that as a health assessment. Because even though that patient technically doesn't have a chronic condition, it's in that age group, isn't it, where all of those risk factors are kind of lining up. So we do need to do some screening activities with that patient. So that's kind of it for me today. I know I'm right on the timing as well, sorry, Julia. Just a couple of quick things. There's a couple of promotions. We're offering like 15% off the next week or so for anyone that wanted to buy any products or services. So you can actually have a look on the website. So that ends on the 31st. That's it from me today. You'll have access to those resources, the tech shortcuts, templates, and slides. And any questions, I'll go through that in the Q&A. Thanks from me, and I'm going to hand over to Julia.
Thank you so much, Jane. And everyone, just be a little bit patient with us, 5 more minutes. I'm going to walk you through how can we translate all of this into quality improvement. So just let me share my screen. There we go. So how do we translate all of this into quality improvement? So usually when we mention quality improvement, it can elicit this type of reaction, right? And let me just ask you a couple of questions. Are you someone who struggles to integrate continuous quality improvement activities to fulfill accreditation and PPQI criteria? Yeah, does you conduct CQI activities but also fail to document your processes? Do you start CQI activities but then lose momentum before completion? Or do you find that assembling a CQI team a challenge and then leaving the responsibility on the shoulders of one individual? The probability is that you answered yes to at least one of these questions. And don't worry, we're here to help. We have a whole team prepared to help you through your journey of quality improvement. So what are some of the benefits of you engaging with the PHN and us helping you through your QI journey? So the first one is you have access to enhanced continuous quality strategies. You have experience, tailored, efficient, and low-stress quality improvement processes. You get expert guidance and support, comprehensive support from meeting accreditation criteria, planning and fulfilling PQI requirements. You can also access professional development. You access to some self-recording CPD activities and training to improve the use of health assessment. And there's also some dedicated resources in our new website and some other traditional support channels in quality improvement. So what is your role in this whole process? What we like to see is this series of steps. So the first one is creating your quality improvement team, right? And a lot of you are clinicians and you have to understand that you're the champions of this process. So alongside with your engagement officer from the PHN, yourself as a practice manager, a nurse-led quality improvement, you lead the quality improvement effort. So the second step would be starting with a 1-hour kickoff meeting to set goals, document them using a plan to study act, and then follow us by 3-month period and see where we are at and just go through that executing that plan of quality improvement. After this 3-month period where you follow up your plan, you engage once again with your quality improvement officer in a 1-hour follow-up meeting to review the process and to finish the documentation of the PDSA cycle. We would like for you to share these PDSA cycles and success stories with your quality improvement and development engagement officers to contribute to the collective knowledge and ongoing improvement. And also at the end, just feel free to reach out to your quality improvement and development engagement officer for additional assistance, such as face-to-face meetings, phone consultations, or any other support throughout. So how are we translating this health assessment into our CQI activities? See, continuous quality improvement doesn't have to be that convoluted. It is a range in this journey. You have options for very simple activities such as ethnicity PDSA. This is an activity that we designed for you to roll out in your practices. So this first PDSA is very simple. You just improve the quality of your data. You improve the recording of ethnicity. And this helps you understand the demographics of your population. It also helps you identify those eligible patients. There's another very simple activity around increasing the number of 715 assessment, those First Nations people. And then we have some other a little bit more complex for those practices that are already along the journey of quality improvement. You have option for a mini audit, and this mini audit is tailored to increasing those 40 to 49 health assessment that Jane was talking about. It is a whole process. It's a more convoluted process. And then we understand that some of these activities might not be for you. We understand that everyone is different, but you also have the option to choose your own adventure. And this is where the engagement officers come and give you all the expertise and can work with you and see what are the activities that you could do to improve the quality of your services. So this is what the ethnicity PDSA looks like. It's, as I said, is already a pre-filled template. It's an example that you can follow. It's very simple for you to roll out in your practice. This is the Aboriginal Torres Strait Islander Health Assessment PDSA that helps you increase those 715 health assessment in your practice. It is a pre-filled template, simple to follow, and we have the mini audit this is what it looks like. This is a more convoluted process, but again, you have the support of the PHN behind you. If none of this is for you, again, you have the option to choose your own adventure. Now, what are the next steps in this process? If you're interested to join in forces with the QI&D engagement officers for health assessment initiatives that could streamline your workflow, reach out to our practice support team. You have the email, you have the new website, and by the way, this website is where you can rewatch these recordings and rewatch all of these resources. You also have resources on the health pathways. So remember, you also have access to health pathways. So we are here to help you. We are here to increase the quality in the services that we provide throughout our region. And then finally, I would like to also invite you to a networking meeting that we have next week. Before we finish, remember that there's a survey coming up. If you require the certificate, you have to fill the survey because there's a question that prompts there if you need the certificate. So please stay with us, fill the survey. The survey is going to help us improve the quality of our webinars and also help us tailor the webinars to your needs. So thank you so much. We're going to leave this slide for a minute if you would like to register to the networking meeting for next week. So thank you so much for joining. Thank you, Jane, for an amazing webinar. And thank you, everyone, for joining.
Thank you.